Everyone's logging on now.
Okay. Okay.
Welcome, everyone. We'll give one more minute to let more people come in, all trickling through, and then we will make a start. Right, seems the trickle. Oh, spoke too soon. All right. I'll start with introductions in the meantime while people keep coming in. I'm Laura. I'm one of the FEES VFSN committee members, and we've got a few others that are joining us today as well that will be monitoring chat, keeping an eye on things for us. So thank you, team. Welcome to our Paediatric webinar. We're really, really excited to have Katlyn McGrattan from Minnesota University here with us presenting. Really, really excited. It's very early in the morning, so we're even more grateful that she's got up really early to come and join us. Few housekeeping bits from us. Your cameras and mics should automatically be off, but if they do happen to come on while we're speaking, if you could just turn them off. We will take questions at the end, and I'm sure it'll be really interactive because Katlyn's really great like that. So if you are invited, then that'll obviously be different. We are recording this webinar and we will post the video. It says in the chat, but actually we do have a YouTube page and the video will go up onto our YouTube page at the end. I will very quickly, if you've not already seen or registered, we are running a face-to-face study day on the 16th of October with the absolutely fabulous Dr. Anna Miles from University of Auckland. If you're thinking about registering and haven't yet, don't wait. Just register. It's going to be absolutely brilliant. It is going to be a mix of peds and adults. So if you're worried that there's not going to be something for you there, I promise you there will be. We've very specially gone through with her what we want spoken about. So it's going to be an absolutely brilliant day. I'm going to stop sharing because you're not actually here to listen to me. I'm going to hand you over to Katlyn. Thank you so much for being here with us today. And I will probably see you guys at the end.
Great. Awesome. Well, good morning. It's great to be here. Go ahead and get myself all shared. And okay, can everybody see the screen okay?
Yes, we can.
Okay, great. Awesome. Well, it's really great to be here. Okay, I was designing this and I don't know. I feel like anyone, like I get sometimes bored of talking about the same thing. So then I'm like, well, how are we going to mix it up this time? Which is always a scary moment for anyone on the other end of things. But what I was thinking about today is this can be really dynamic. If you have questions or you want to expand on any of the topics that I'm talking about, please feel free to interject, whether that's however you're capable of doing it on your end. And I'll maybe take a moment after the different sections that I'll be talking about. And if if you have like any specific questions on direct application, happy to chat about it. I'm a clinician as well. So I think that's always my question when I'm doing research is how does this apply to clinical? So my thought today is I'll talk about some of the research that we've been doing and really how to improve, this is specific to video fluoroscopy, but I think the principles are important to think in any form of our assessments. And then really talk about some of the new findings that we've had coming out of our lab. We've had a pretty busy research year in our lab, which has been great. And so getting a lot of different studies completed and some things related to what we've been finding with video fluoroscopy as an outcome that I thought y'all may be interested in and talking about further. So without further ado, let's jump in. So the first section I really wanted to dive into is regarding, what is the state of the science on swallow studies, especially specific to infants, but this really goes across populations as well. So just to start out, when we look to the literature, we look to our governing agencies, wherever you may be, on what are our standard practice parameters for swallow study. The main thing that we can see here is if we look at radiology, for example, they have a beautiful set of evidence-based guidelines to really designed to help provide the clinicians that are using their different exams the best ways to do them. Okay. And this is really important. It goes through things like clinical competencies that are required in order to do different radiographic exams, the procedural implications, how they should be executed, how the exam should be interpreted, essentially everything that I think anybody on the patient side of things expects every area of healthcare to cover. And certainly, I'll go through this and I'll be talking about protocols, guidelines, I use them a little bit interchangeably because at the end of the day, as the American College of Radiology points out, is that the ultimate judgment regarding how appropriate any specific procedure is or the course of action resulting from any procedure has to be made in light of the circumstances around that. So, I think the goal is trying to get things more standardized, more procedural, based so that we're all doing similar things. So a patient can go to, our children's hospital here and expect a similar experience as if they go to Great Ormond Street, right? But also that it's not rigid. And I think that's the key thing. I'll be talking about some protocols that we have in place, but knowing that certainly I sometimes don't follow that because the patient situation is not conducive to it. So when you look at this paints a really pretty picture. And like I said, I think a lot of patients imagine, and I think providers actually imagine this type of thing exists everywhere. But I think that if you actually look at the part on swallow studies for radiology, at least, you can see that it's very, very minimal. There's not much there. And the key reason is they don't have evidence. So in order to make these standard practice parameters, they need to have a body of evidence to draw from. And as many of you are familiar in the field of pediatric feeding and swallowing, we really don't have much out there. It's growing, which is encouraging, but generally speaking, on any given topic area, in other areas of medicine, there's study upon studies, there's replication studies, there's all of this stuff from which you can create best practice guidelines. And that is certainly not the case for video fluoroscopy, or it hasn't been to date. And this is a huge urgent need, as anyone probably joining this is aware, because without these, we really are reducing the yield that we're giving to a patient in terms of the validity of the exam, reliability, clinical translation. We're increasing radi exposure and fragmented care. So what I want to talk about is a little bit of how we've gone about in trying to fill this gap. I was raised by my father is a nuclear engineer. I think I've talked about this to other people. And so we grew up in a house where we spoke in code, ones and zeros. It was very algorithm based in things. And so I was just raised it's fine to have a problem with things, but you can't just sit and say there's a problem, not do anything about it. You have to find a solution. Otherwise, I don't really want to hear you complaining, which is, I think, a pretty good principle. So I figured if I was going to complain about the fact that we have no standard practice guidelines, that we should probably start to work in looking at that. So the first thing, as many of you familiar, this is certainly a hot topic, is pulse rate. And I'm not going to go into this for too long. I'll just kind of highlight some of the big things because I think a lot of people are familiar with this and the need for it, but I think it's always good to come back to. So certainly like swallow studies carry radiation exposure, which means there's a carcinogenic risk. So the big thing is that we're worried about causing cancer in the future, right? Simply put. Just, I think there's a few core principles to keep in mind. So in a field where we've really built the field of pediatrics based on adults because they're so far advanced from a science perspective, I think that's great, right? Take what people have done before us and learn. But it's also dangerous too because there is not a direct translation. And so I do want to highlight that in this slide is that, we talk about radiation exposure in adults. And sure, that's something to keep in mind, but generally speaking, adults are getting these when they're adults, right? And typically towards the later stages of life very often, at which point your concern of causing cancer due to radiation exposure from a swallow study exam, which is very low radiation exposure, it is quite low, right? You need time for that radiation to damage the cells. In this case, we're worried about those cells in the kind of field of view, those organs. So thyroid cancer is the biggest risk here, with women at greater risk of developing thyroid cancer than men. But generally speaking, you need time for those cells to get damaged, I guess more so the DNA behind them, and then that will then lead to cancer with time. And so in adults, yes, we want to keep radiation exposures lower, but the chances of developing a cancer in the amount of life you have left, unfortunately, as you get older and start needing swallow studies, typically is much lower. Now, infants are a very different story for many reasons. One is that they have a much longer life for this damage that we're causing from this radiation to turn into potential cancer cells. But also because of just based on their age, they get a higher radiation exposure based on how their tissues are present. So even when, working on a grant right now looking at doing swallow studies in like healthy individuals, babies, so that we know what normal is, right? Which you can imagine requires a lot of justification for the radiation exposure and the risk to benefit. So in writing this up, even comparing, looking at like a newborn baby versus a 3-month-old baby, there's a notable difference in radiation exposure between that small time frame. So what we do know is the younger you are, the more exposure you're going to get. And in itself, even if the exposure was held constant, you have a longer time in life for that to lead to problems, right? All of that being said, I think we should never take the radiation exposure lightly, and I certainly don't. As you'll see, a lot of the research I do is trying to figure out how we can cut this down. But also I want to keep in mind like where this is relative to like the big scheme of things. So here you can see a swallow study here. This is relative to a chest x-ray. So swallow studies are notably more radiation exposure than chest x-rays, but pretty much less than most other radiographic procedures. So I put upper GI here. If we did like diagnostic radiology, it's exponentially higher. So just know that these are generally quite low exposures. And the annual, like just as part of living on Earth, you get 3 millisievert of radiation exposure. So I think putting this number in perspective to like, this is how much we're going to get just from existing, right? It's a pretty small portion of that. Certainly we don't want to keep increasing it, but also do a test if it's clinically indicated without that fear. And I think talking to parents about that is important to understand some concepts behind it. As many of you are probably familiar with the ALARA principle, so this is just the principle that guides fluoroscopic procedure execution. And the concept is keep radiation exposure as low as reasonably achievable. The key word here being reasonably achievable. So we can cut down radiation exposure by doing lots of things. Pulse rate is like the number one, I think, that radiology goes to. But swallow study duration, magnification, collimation, we'll talk about these. But if you're cutting down, radiation exposure at the cost of actually diagnostic yield, then you shouldn't even be doing that exam. And I think that's really what it comes down to. When I hear a lot of clinicians talking about, I'm frustrated because radiology is saying that they want to be doing 15 pulses per second. We can't convince them to do otherwise. I think that is the key point that I always stress is, one, bringing them the data, because let's just be real, radiology, generally speaking, swallow studies are not on the top priority of their exciting, I'm going to say most up to date in all of the research regarding radiation exposure in swallow studies. Typically speaking, that's lowest on the sexy procedure list for them. So I think that assuming that you probably know more on the research on the importance of pulse rate for the yield that we get from that exam is a fair assumption, but also communicating with them within a way that does not give off the impression that you feel that way is always a good start. But I think that's always what I say is hey, this research shows that we're actually reducing our ability to actually make helpful clinical decisions if we're below a certain thresholds for these different areas. And so it's really making it so that this is not a reasonable reduction because we're not getting the yield we need from that exam. And it was just unnecessary exposure at that point. So let's talk a little bit about pulse rate just as an overview. So, when people often reference this as frame rate, which is actually a different concept, but overall the concept applies similarly, is that when you're doing a swallow study, I don't know if you were little and average cartoons on paper, and then you move the paper really quick and it makes it look like cartoons moving. That is the same concept of how swallow studies are done. So the X-ray machine is turning on fluoroscopy very quickly to allow us to capture these pictures. It's not on continuous is quite misleading. That just means that it's turning on 30 times per second, which is very fast. That I will say, when we say continuous fluoroscopy, the one that we're saying is the gold standard, the highest generally that is clinically available for us. I just want to keep in mind that this is actually quite slow compared to swallowing physiology. So there's different formulas to determine for engineering on how quickly you have to sample something. So in this case, take pictures, if we're looking at measuring arm movements on how quickly the sensors need to collect that data. But there's certain formulas that you need to use to calculate what's the optimal pulse rate. And this is actually quite low for even the physiology of swallowing. So much to the point that, I collaborate a lot with Rebecca German, who, if you've never met her, she's awesome. She's a great woman scientist who is just hilarious, and she does a lot of piglet research. And the fluoroscopy units we use for the piglets pulse at 100 pulses per second, based on those principles. Now, that's not an option for humans, but just keeping in mind that 30 is actually not very high in the big scheme of things. But if we look here at the top, if this black bar is representing the actual swallowing physiology, right, where, there's no segments in it, it's just a continuous process. And what we're trying to do with diagnostics is capture images at certain times. So if this is a patient that has airway entry, whether it's penetration or aspiration, you don't typically, this is an example I just took from one baby when going through, but you're not going to see that the entire swallow, right? Usually the beginning is fine, or the end, you might not see it. It's really this kind of sweet spot right here in the middle part where you actually see it. And if you're using continuous fluoroscopy, in this example, that equates to about 3 frames where you can actually see bolus airway entry occur, so penetration or aspiration. If you cut down to 15 pulses per second, right, just based on modeling, you're going to, in this case, you will only see it on 1 frame, and who knows the depth of it, right? And you could miss it altogether, pending the timing of how this goes. And in this case, at 7, you miss it altogether. So I think this is kind of showing you that this is when the actual camera is pulsing the fluoroscopy, which is why it's called pulse rate, and then therefore recorded on your system. And so if you're pulsing at anything but continuous 30 pulses per second, you are 100% missing things. Now, the question that you'll get from radiology perspective is this a clinically significant thing I'm missing? They say, we were saying before this, we see penetration, we see aspiration, but are you seeing that it's actually reaching the level of the vocal folds? Or are you seeing everyone? Like, how sure are you that you are seeing it? If you missed it, then you don't know that you missed it, right? And I think that's the problem. So again, here's a swallow study I went through each frame on my computer and took a screenshot of each frame. And this was like immediately prior to and during bolus airway entry. So here you can see this is where prior to the swallow, where they initiate a swallow in the piriform sinuses. Here are the two frames in this case for this young infant where you can actually see that they had penetration. And then after, this is at maximum contraction, and you can no longer really see penetration, or you wouldn't be able to say that with certainty, right? And how many times have we seen things and we're like, ooh, is that penetration? Is that aspiration? I don't know. Well, this is probably not helping that situation, even at 30 pulses per second. If we look at the same baby and we, just take away some of the images to replicate 15 pulses per second, you can see in this case, we see only one frame where you can see penetration. And like I said, if this was just shifted a little bit, there's a chance you could have not seen any. And at 7, again, we're really missing a lot. So I think that is the key thing. 7 and below is really, hard to be sure about any kind of objective measures that you're making. In fact, a lot of times you see it in the oral cavity and then it's already in the esophagus. So it's really hard to consistently judge what's going on. And I would argue probably, yes, it could give you a big picture ideas if there's tremendous impairments in airway protection or bolus clearance, but not really anything super granular for more of those mild cases that we're actually often looking at. So, back before, I was out on my own, we were looking at this using the MBS IMP. So I studied under Dr. Bonnie Martin Harris, who many of you know developed the adult MBS IMP. And so when I was doing my PhD, we were really focusing on this was new at the time, and people were hesitant to use the protocol in that because they were saying it was going to increase floor time and all sorts of things like this. It's interesting just how change is hard. Change is hard for everybody, and which I get. So we're doing a series of investigations to look at different variables that influenced swallowing and the ability to judge it. And one of those was pulse rate. And so we teamed up with Heather Bonilla, who's now, I would say, probably one of the leaders in looking at pulse rate in adults and pediatrics. And we did this simulated kind of study where we took a bunch of swallow studies. We then simulated that they were captured at 15 pulses per second when they were originally captured at 30. We had clinicians rate them at both and make recommendations for diet based on that. And what we found is that at 15 pulses per second in an adult, that we had reduced diagnostic validity, resulting in our inability to reliably judge physiologic deficits, bolus airway entry, and also it altered our diet recommendations, which I think is what it really comes down to. I love physiology. I love quantifying it. But really at the end of the day, it comes down to like, how does this actually influence patient care, right? Like narrow, does it matter if you make a judgment of trace versus narrow for tongue-based retraction? I don't know. I mean, people really haven't done much research into that, which I think is desperately needed. But at the end of the day, it's if what you're looking at on the image is altering what you think is the optimal diet to recommend, I think that is of tremendous clinical significance. So we demonstrated that here. I know Heather Bonilla has got to be coming out anytime soon. She had this really big grant and work doing the same thing in a really large scale in infants. So I'll keep an eye out for that. There's not a ton out in infants. And I think the key thing is when looking at the studies for infants on pulse rate, to keep in mind that there's a certain approach that you need to take in order to like demonstrate if it's effective or not. So if you take swallows that look perfectly normal, right, they don't have any problems at 30 pulses per second, then putting them down to 15 and saying, oh, okay, our recommendations were the same, that doesn't really help, right? Because they were normal to start. So you wouldn't expect that you missed anything. So you really, in order for these studies to be done, need to start out with children that had problems that were found on 30 and test it from there. So when you're looking at the available literature, just keep that in mind, because I know there have been some studies published looking at this in infants saying, oh, actually 30 isn't needed. And if you look at the methods, they actually didn't start out with kids that had problems specifically. It was kind of a mixture. The next thing I want to talk about in terms of reducing radiation exposure is just how this, change in pulse rate influences the actual dose, because that's what we care about, right? So I was always under the assumption that if you go from 30 pulses per second to 15 pulses per second, that's right, half. And so it would be half as much radiation exposure. Seems like a logical thought process, at least it did to me. But in fact, that's not true. It's only about a 25, now this depends on your radiographic equipment, but generally speaking, it's only about a 25% dose reduction. And the reason for this is they need to increase the milliamperage for the equipment to actually like pulse at those levels when it's 15, because it has to start up. So it's not like a one-to-one relationship as one would expect. So I think that's also important to keep in mind. Next, we're going to talk a little bit, we'll talk more about protocols and things like that. But like I mentioned, at this time, we are also looking at, how else can we reduce radiation exposure? And that's specifically looking at like fluoroscopy time. And using the adult MBS-IMP, we actually found that using the MBS-IMP did not increase radiation exposure in adults. That was a huge concern at the time. People were saying they were hesitant to use this like standardized protocol because it was too much radiation exposure, when in fact that certainly was not the case. So, that brings me to like the analysis of swallow studies and where we're at there. Many of you are familiar. When I started my PhD, Dr. Martin Harris was developing the baby VFSS IMP with Maureen Leftengrave. And this was like a really new area for her. When I started my PhD, she's like, you're welcome to study under me, but I will fully disclose, like the only thing I know about babies is that I had one. And I truthfully didn't even know what to do with her for a while. So I said, I'm up for a challenge. Let's do it. So really at that time, they were trying to apply the same science that they had done in developing the adult MBS-IMP to pediatrics. And so that involved a really lengthy process that I think until you develop a tool, you really have no conceptualization of how much work goes behind creating a good tool. Like we think about it of like, all right, let's just make a scale that has like 4 outcomes and then everybody can use that. And then we have, we're using all the same thing. And that's a good start, right? That's a good premise. But generally, if you are judging a score of 2 different than I am, and we're actually finding that our scores of 2 and 3 are the same thing, then that's not a good scale. And so that's really what this process was developing the initial baby VFSS IMP, which is a mouthful tool. So there's a very lengthy process behind it. I won't go into all of the details because it's probably beyond what you actually care about at this level, but the papers are out there. You're welcome to read them. Generally speaking, what we did is they took the adult tool. They got a big group of experts in the field of pediatrics, and they said, which of these components make sense for infants and which ones don't? Do we need any additional ones? Are there different score variants that we may need for infants? And they came up with this tool prototype. They then took a cohort, I think there were about 5 of us, if I'm recalling off the top of my head correctly, and they trained us and they created these rules for a score of 1 means this. If you've gone through the adult tool, it's the same kind of concept. We were trained in it, and then we scored a bunch of exams. From that, they did analysis to figure out, all right, where are they reliable with each other? Where are they not? And then consolidated scores. So for example, maybe tongue-based retraction started out having 5 variants of what you could rate it as, but we weren't reliable at 5 variant level. And so it got collapsed down. And so that's why when you're looking at these tools, specifically here, the MBS-IMP kind of series, that's why they don't all look the same. And a point of maybe, I don't want to even say frustration, but like at first you might say, what in the world if you're adult trained and then you go to do the pediatric training, it is kind of, you're doing shifting back and forth because not all of the scoring for the same physiology is the same. And that's because in infants, if you do swallow studies, you can appreciate it's a lot harder to make out slight differences. And so some we couldn't achieve reliability at that same level. So we did the reliability testing, the tools further refined. This process was on and on until we eventually got to a tool where we could achieve 80% reliability, which is what is expected now. So this tool is now available. It was released this fall, the Baby VFS IMP. You can do the training through Northern Speech Services. I have no stake in the game at this point. I was just involved for the early science, so I have really no conflict of interest there. I think it's a great tool if you're looking at sharpening your skills in how to interpret swallow studies, and as well as just making sure that we're all speaking the same language. I think it's really a wonderful tool for that. So here you can see that these are the different domains that the different physiologic processes are collapsed into. And here you can see the different physiology with the score variance on the right. And here the red marks are indicating those components that were added for infants, such as sucking, right? We don't have that in adults. And then these pink ones are the ones that are the same as adults in terms of their title, but their score variants are different. So we have a couple that did get changed in their scoring based on reliability. So I would really encourage you, if you're practicing in pediatrics, to take this training. If you've done adults, you know it's not a quick process. I have all of my graduate students go through the adult MBS IMP training, and just stress that yes, this tool is reliable. There is sound science behind it, but also know that it is categorical score, which means that there is some subjectivity. So I say, always tell them, like, rest assured that, like, if you're like convinced, like, this is a score of 2, this is not a score of 1, I don't agree with this, then like, that's okay. Take it and move on, because generally speaking, that is part of just having like a categorical score. It's going to be some score variables are going to be like in that middle zone where it's not a clear-cut answer, and that's okay. Like, we don't need perfect. Once you get through reliability, great, use it, move forward. Do I deliberate extensively between a score of 1 and 2 in clinical practice if it's in the middle zone? No, I don't. I score up. That's the general rule, and we move forward, because really that one isn't going to be influencing my clinical decision. So, I think that's the point, is to get more standardized and similar amongst ourselves. All right. And then the last part of more of like this protocol kind of section that I want to talk about is the timing of visualization. And then I'll open it up for some discussion or questions, or, if you've tried it and you're like, hey, this is garbage, totally open to that conversation too. I very much think that it's important to question things and get pushback, right? Like, you can't just like jump on board with everything. You've got to like have appropriate pushing back. So let's have a little discussion about it after this section before we move on to some of the other cool data that I think you'll be interested to see. So at the time, the pediatric tool was being developed. Like I said, I was just doing my doc study at the time, which seems a little bit of a lifetime ago right now. And what was striking to me during that was that if you're familiar with the adult tool, there's a protocol that you follow when you actually execute swallow study exams. You 5 ml, 5 ml, cup sip hold, sequential sip, you go through this whole sequence, and it generally is the same across patients unless there's some impairment where it's not safe to continue, and that's accounted for in scoring. But in the pediatric one, we didn't have a protocol. And that, from the beginning, I think for all of us, it kind of struck us as like, this is different. This is something that we need to think about. But I think at the time, it just seemed like this would be harder to standardize in infants. Like, how do you do it, right? You can't tell them what to do, and you're kind of at their mercy of how compliant they are. And so we said, well, let's not tackle the world all at once. Let's just work on developing the tool and then move forward. Well, once the tool was developed, we had a great outcome variable that I said, well, let's actually see, like, how much does when you turn fluoroscopy on influence your swallowing outcomes, right? I know for me personally, I had kids that like would have a swallow study and then they would come back for a repeat and parents are like, man, they got worse from their last one. And I was like, I don't actually think they did get worse. This score certainly makes it seem like they got worse, but I think this is just sampling. Like, this is a good example of this is a moment in time that we just didn't capture, and there's variability in infants. But I didn't really have like a solid foundation to stand on for that. So what we did is we looked at the literature, and many of you are familiar, if nothing else, from just clinical observations, that as infants feed, sucking, swallowing, breathing physiology changes throughout the course of a bottle feed, right? Or a breastfeed for that matter. So sucking rate declines, swallowing rate declines, sucks per swallow, right? You're going to have an increase in that, and sucking amplitude generally declines as well. And we know that, you know, a huge limitation of swallow studies is that we are limited to capturing a sample of swallows and extrapolating from that what this patient is doing clinically in a way that matters. And I don't know that anyone can give you the clear-cut way to do that. That is the million-dollar question, right? Like, based on this, what is the best next step? And I think that's really hard. But just doing like a brief, you know, calculation. So infants on general have a bowl size of 0.2 ml. And if they're taking 4 ounces for that feed, you know, maybe they're a younger infant and they're swallowing at a rate on average of 1 swallow per second or so, then that means they have about 600 swallows per bottle feed, which is a lot of swallows, right? Over here, you can see the percentage of swallows we're actually capturing. So if we do fluoro and we look at 20 swallows, that's 3% of their feed, right? And then on average, that's 24 seconds of fluoro time. If we capture 50 swallows, right? Well, that seems like a huge increase, and we're definitely increasing fluoro time, but we're still only capturing 8% of the feed. And if we capture 75 swallows, which I would say generally speaking, most people hopefully are not doing on a single consistency, then we're greatly increasing fluoro time and we're only capturing 13% of the feed. So best case scenario, you have to extrapolate for 87% of swallows in the feed, which I think this is the tricky thing when determining some type of procedural protocol, is finding out how many swallows is enough, right? So that we feel confident enough in what we are getting to extrapolate, but also knowing that, like, even if we captured 75, right, then we're still missing a ton of the feed. And so really, like, how much is actually needed to make that difference up? So we did a study, a really simple study, really just to look at the stability of swallowing. So we knew fluoroscopy wise, as I think most clinicians know, is that the swallowing is changing in terms of airway protection and things like that. But people hadn't reported this largely at the time, or at least not in a systematic way, because there was no validated outcome variable. But now we had the baby MBS IMP that we could use to really systematically look at this. And so we developed this protocol. I was in Charleston, South Carolina at the time, and tired. So we just called it the Charleston protocol because that was about the amount of energy I wanted to give it. And we said, all right, let's think about clinically what would be like a reasonable protocol to follow for bottle-fed infants. And we said, we knew from the research that suggested that breathing and sucking rate changed very drastically between the first 5 swallows and those at 30 seconds. So we knew we wanted to look at this kind of time period to see what would ideally their best be, right? Which I think is good to know. And then see the point where things are starting to change at 30 seconds. But we knew clinically, I never stop exams at just 30 seconds unless there's a pretty profound impairment. So we would want to go further than this. But also knew the key limiting factors were ingesting a ton of barium is suboptimal, right? If it's not helping things. Not to mention radiology doesn't want to they don't want to be sitting in that fluoro room for a prolonged period of time, just waiting for a baby to, feed for 15 minutes to take images, at least not in the United States. I don't know, maybe other places, but my hunch is probably not either. So what we did is we said, okay, let's do 1 minute after and then another minute after, and this we can use as a starting point. That was really all it was at that point. So we'd give the baby bottle, we'd let them keep eating, drinking. We wouldn't, apply anything by taking the bottle out. We would just turn fluoroscopy on to look at 5 swallows at each of these times as they continued to feed. We were really looking for this kind of fatigue factor. So from this study, we excluded infants who did not maintain a latch or they required some type of intervention before the completion of these first 3 time points, because we really wanted to be able to see the change over time. So keep that in mind in the data that you're looking at, as we excluded kids that had really more profound impairment and couldn't complete this protocol. We looked into demographics, primary diagnosis, swallow study indication, and then we scored the swallow studies by 2 clinicians that had used that, had met the 80% reliability scoring for the baby MBS-IMP. So our sample was 30, and you can see, generally speaking, we had infants, the average postmenstrual age was 55 weeks, and it was just any child that was referred for swallow study. So we had a wide variety of what their primary problems, underlying swallowing issues were. Just by nature of inclusion, all infants in the study had the data on the first 3 time points, but some of them did not achieve this last time point. And typically that was because they had profound impairments that we had to stop the exam. So I think keeping this in mind in general is really important, because when we're looking at the differences between 1 minute 30 and 2 minute and 30, you'll see that there's less significant differences between those time points. Do I think it's because swallowing stabilized? No, I think it's because we excluded the kids that were doing really poorly at that point. And on average, our average fluoroscopy time was 1.5 minutes for the entire, procedure. So well within a reasonable radiation exposure time. And what we found across all of the outcomes that we looked at was that sucking and swallowing, exhibited a decline in integrity throughout the course of a feed. So this is looking at the number of sucks per swallow at each time point that you can see here. And so when we move from the first 5 to 30 seconds, we see a significant increase in the number of sucks per swallow. This increases again at 1 minute and 30 seconds. There's no significant increase at 2 minutes and 30 seconds. But again, this is very likely just sampling bias, because those kids that were exhibiting the greatest decline in sucking and swallowing didn't actually get collected in that time point. We then looked at oral bolus hold, so spilling of the bolus into the pharynx prior to initiation of the swallow. We saw the same thing. So this, we looked at the percentage of swallows where the bolus escaped to the pharynx. And what I think is interesting across all of these, I'm very interested in the percent that suboptimal physiology is occurring, because I don't know, at least in my clinical experience, like very rarely do I have a swallow study where an infant doesn't initiate their swallow in the pure forms at least once, right? Like I just rarely ever see that. I can only think of a couple times actually. But they might only do it once or twice versus like every time. And we don't know currently if that's of clinical significance, the frequency. It seems very likely that it is. But my point being here is that even in the first 5 swallows where things are optimal, everything is the best, these infants, 40% of swallows on average still had escape to the pharynx. Here is initiation of swallow, and this is looking at initiation below the level of the vallecula, so between the vallecula and piriforms or in the piriforms. And again, same thing, we're seeing not that it's like 0% at the first 5, still we have on average 40% are initiating below the level of the vallecula, but this increases as you progress throughout the protocol. And then the timing of initiation of swallow. So how long does the bolus sit at that location prior to initiating? This is the one where, for lack of better words, perfection was found in the first 5 swallows. Generally speaking, infants initiated immediately once it reached the location, the first 5 swallows, but as the feed progressed, this significantly increased. And then, of great interest, this is the primary outcome people are generally asking about, is bolus airway entry. So this is the percentage of swallows that had penetration or aspiration In my own reporting, I actually break it down by what percentage of swallows had penetration. Generally speaking, aspiration, we stop the exam after 1 or 2 events of that, right? We don't always stop it right away, but if you see them aspirate twice, it's pretty hard to keep going because you know it's going to change your care for the most part. So here we can see there was no significant change in penetration or aspiration between the first 5 and 30 seconds, but there was a significant increase between 30 seconds and 1 minute and 30 seconds. So just putting this into clinical context, this is based on seeing up to 2 minutes and 30 seconds. So again, keeping in mind as we go through this, if kids exhibited aspiration, maybe they would have aspirated at 5 minutes into the exam. We don't know that. We didn't look at that. But based on the time points we did look at, that if we look here, this dot kind of is the percentage of infants that had penetration that was missed if you looked at just the first 5 time points. So here, if you looked at just the first 5 swallows in the exam, which I think most people do not do, then nearly half of the children who exhibited penetration at some point in the exam would have been marked as having no penetration. This actually reduced drastically at 30 seconds. So you only have about 7% of the infants who had penetration missed if you looked at 0 and 30 seconds at the feed. And then actually all of the infants were captured that penetrated at 1 minute and 30 seconds. And I think this is pretty consistent with what I see is like if a child is going to have penetration, generally speaking, you'll see it pretty early on. It might not be super frequent, but you'll see it at some point before. It's not like you're searching for that event to happen. Aspiration is the one that's a little trickier, and that's what makes things hard, right? So if you looked at just the first 5 swallows, 67% of children that aspirated within those first 2 minutes and 30 seconds wouldn't be captured, so it showed no aspiration. This goes down slightly if you look at 30 seconds, but generally speaking, kids aren't typically aspirating at 30 seconds either. We then move on to 1 minute and 30 seconds. This closes the gap a lot further. So it really seems like it's almost like a minute and a half of fatigue, for lack of better words, that infants generally need to actually start to have this degradation where it results in aspiration. And by 2 minutes and 30 seconds, this gap is completely closed. I think this, looking at this data is helpful too for me for, clinically better understanding different populations. So for example, I had an infant the other day that was healthy, meeting motor milestone, like otherwise totally normal, but has been having recurrent respiratory infections. They did a swallow study as a result, and we saw aspiration, in the first 30 seconds of the exam, right? So in the context of developmentally normal, otherwise like no neurologic deficits, no neurologic swallowing deficits, to me, that's pretty notable, right? We don't generally, I think for this baby, it was actually in the first 5 swallows. And I was like, this is actually pretty uncommon. We rarely see kids aspirate in those first 5 swallows if they don't have any profound impairments, which this trial didn't. Like bolus clearance was fine. Everything else looked fine other than airway protection. So that is a kid, like this is where I think future research is needed, is like we refer them over to aerodigestive clinic to like do a bronch to see like, is there a cleft or something like that? I think that would be really interesting to see. I don't know, it's anecdotal at this point, but it does seem notable. Like when I have a otherwise healthy child that aspirates in those first 5 swallows or 30 seconds even, it's pretty notable to me because it's pretty uncommon relative to further on into the feed. And then we did a subsequent study, just looking at the effect, kind of replicating what we did in that adult study, replicating it for the infants using the Charleston protocol. So we compared at the same institution prior to when we implemented the use of this protocol at our hospital to after, and we found that when we initiated the use of this protocol, we cut down on fluoroscopy time and we cut down on fluoroscopy dose significantly. So, again, like radiologists love this, of course. And, for us in our center, particularly now, like this is what we did. We implemented at MedU of South Carolina, and I know clinicians do now. And we do this now at Masonic Children's Hospital where I'm at. Our radiologists love this because I think it engages them more in the actual exam than they were being engaged before. I think it's kind of I guess for lack of better words, unengaging when you have another clinician saying turn on, turn off, turn on, and you have no idea when they're going to do it. And from the radiologist perspective, if 5 different clinicians come in throughout the day and they each have a very different amount of time they leave on fluoro, and when they turn it on, you could see how it's kind of discrediting to our profession in terms of like the standard practice parameters of like, how are you actually doing this exam and what matters? So that's what, I mean, that's one of the many things I do like about using the Charleston protocol for our bottle fed infants is it really, the radiologists know what to expect. Our fluoro times are low. Now, certainly after you complete that initial series, then you apply interventions, right? So if they're having problems during that, you clearly use your judgment and you can stop the protocol early or you test out different things. But I think generally it gives a general guide that clinicians can go from. And I will say, like when I first arrived at Masonic it was like 5 years ago now, they were using 15 pulses per second. And over time, at least for anybody that uses the Charleston protocol, the radiologists have no problem using 30 pulses per second because our fluoro times are low. And I think it gives a certain level of credibility to what we're doing. I do know certain departments that in our hospital, they have different departments doing swallow studies, which is a whole nother thing, but don't use it. And they actually, the clinicians from that department said, like, why is it that the radiologist won't do 30 pulses for us? And I was like, well, I don't know. Why don't you ask them? And they said, it's because you're not using any protocol and you're having really long fluoro times. And it depends on what clinician's in there on how many swallows they're looking at. So our times are already really high. We don't want to increase exposure further. So I think this has been a really, that was like enlightening from their perspective. This has been a really good option for us in kind of getting more credibility there. The last thing I want to point out is, as I mentioned, we didn't look beyond 2 minutes and 30 seconds here. I know in my own clinical practice, I've wondered, like, maybe we need to look longer, maybe we need to look at 3 minutes and 30 seconds, or, who knows what. What I found is, generally speaking, when I look at that next time point, it doesn't drastically change what I found. I mean, like sometimes maybe I would see aspiration, I didn't see it, but you could play that game forever, like you could say, okay, well then I need 4 minutes and 30 seconds and so on. And so at this point, I've thought about like, maybe we should do a study looking at that 3 minute and 30 second time point. I don't know that I actually will do that anytime soon, primarily because I think at some point you need to call it a day and be like, okay, we have a moment in time. And if there's a certain clinical indication that you're like, this child never has problems until X time, sure, that like is very reasonable to say, let's do the protocol and then let them feed for like a few minutes and then look at 10 more swallows, right? That seems like a very reasonable modification. But I think at some point for me, I just feel like we have to just say, well, we're working with a limited set of swallows that we're going to capture, and we have to extrapolate from there at some point. Okay. That being said, why don't I take a moment, if there's any questions, comments on implementation, anything that you want to kind of add feedback to. I can't see the comments thing, so type them in if you have them. And I'm happy to chat before moving on if you have anything else.
There are a few questions in the chat. I think you've just answered one of them with the, if we stop at the 2 minute 30, are we potentially missing something by going further? But I think it's really pragmatic to say, if you've got something really specific to look at, go ahead and look at it. There's some questions about the baby VFS IMP. Is it mainly for infants where bottle feeding is their main way of taking fluids? Do variables change in reflexive versus volitional feeding? Any thoughts on that?
So the baby VFSS IMP is specific to bottle fed infants, that tool. But I would say, like, generally, I know in discussions with Dr. Martin Harris that I use the adult tool with anyone that's not bottle feeding, because I think the general physiology is more consistent with that. What was the second question about transitional?
So do variables change in reflexive feeding versus feeding, which is more under volitional control? So I guess when you get to that sort of 4 to 6 month point with your bottle feeders where they're starting to do a bit more, and is there something that changes in that?
hasn't been explored to my knowledge yet. So I think, again, now that we have a reliable outcome that we can easily quantify these things, that those are great questions that we can start to look at for sure.
Yeah, and then I think the rest were more around the time points. And so
Yeah.
does anyone else have any other questions?
I would say try it out. I think, like I said, change is hard for anybody. And I know when we first started this, I worked with a clinical team that, like many of you, we're all very good friends. And they were like, oof, I don't know about this. Like it feels like not right kind of thing. But now they're like the best. They're like, we love it. So I think give it a shot. I would say I encourage you to kind of give it a shot. Some kids aren't going to be able to do it. For example, here's a great example. I had a baby the other day that I was doing this on, and they had such an efficient suck to swallow ratio. It was like 4 sucks per swallow every time from the beginning, like not with fatigue. And so for that baby, they were so slow to start that their first 5 swallows ran into 30 seconds. And so in that case, you have to modify things, right? So like in that case, I didn't look at 30 seconds because I just finished looking and it was already a lot of floor time. So I said, scrap 30 seconds. Let's, like move forward with others. This was a baby that even if I increased the flow rate, they still had a high suck to swallow ratio. So they're clearly like down regulating sucking intentionally, it seemed. So I think you have to use your judgment, like, and things like that. Totally reasonable. I think it sounds like when I present this, everyone's biggest question is like, are you missing things at 2 minutes and 30 seconds? And what I have found, because like I work clinically, but primarily I do research. And so it gives me a really cool opportunity to like just kind of observe what happens clinically and think about it from like a research standpoint. And so what I found is like when I observe swallow studies that were done not using this, if I actually record like time when they turn on fluoro, it's well within 2 minutes and 30 seconds. It's just not standardized. So it feels like it's much longer than that. But generally speaking, at least the clinicians I've observed, they're not usually like having babies feed for longer than that time. When you're sitting like after the 30-second time point, and you're like just looking at the clock waiting for a minute to pass, you'd be surprised how long it feels. Like everyone's like, are we there already? It seems like forever. So it makes me feel very impatient, but I think everyone kind of has that vibe. So I would say if nothing else, even just for your own exercise, if you're not willing to try it out, just turn on a timer when you start your swallow study and turn it off when you're done testing that consistency. And just out of curiosity, like from the time they start sucking until they're done, like how long does it go? It's probably not far beyond 2 minutes and 30 seconds would be my gut. So, all right. Well, if there's no more questions on that, I will move on to kind of the next topic. So we did all this research, looking at swallow studies, how we can standardize things. And really our main goal of this was to like make exams more valid and accurate, right? Reliable. So that if, like I said, the example to start, like if a baby does worse on their follow-up exam, that we can better, and I'm not saying this will ever be perfect, better rule out that this isn't just because of the swallows that we sampled or not. Or like I use this to monitor my neuromuscular patients. So I can say like, oh, they have penetration on this percent of swallows because I know they're captured at the same exact time. And then I can compare it in 6 months and say, oh, it's actually increased. This is concerning kind of thing. But what has always not set well with me is that we know a lot about normal swallowing biomechanics in adult. Like, there's been a lot of studies looking at healthy, normal, non-dysphagic adults and what is normal swallowing. This is the study we have in pediatrics. So I love, like, some people like classic like vinyls and stuff. Like I'm a loser and I collect like old manuscripts, which is fine. And this is like one of my favorite studies. It's from 1958. And this is the first I've seen, maybe there's others, but this is one of the first times that I've ever seen them publish on a swallow study. And they kind of are just, it's like the way the way they describe it would never fly now. Like it's like such a descriptive piece of art. It's like almost like they're telling a story of physiology. So like this is the results section. As the bolus moves downward, the posterior wall of the pharynx was brought forward, displacing the soft palate towards the dorsal surface of the tongue. Like there's no quantifiable measures in this entire manuscript. There's no like, this was quantified and tongue-based retraction was this, or they don't even talk about aspiration or penetration in this paper. But it was really the first to like actually describe bottle feeding physiology, which is really neat. But also really horrible that we haven't come further at all in the science from this time, from a swallowing perspective. Certainly we've captured other areas, but not from a swallowing perspective. And this is huge, right? This clearly like limits our ability to delineate like normal integrity from swallowing impairment. And I think on many levels, right? For example, the example I gave before of tongue-based retraction of trace versus narrow and things like that, like, is that clinically significant? This would come up for me when I was doing routine swallow studies on my spinal muscular atrophy patients before they would get like a disease modifying treatment. And we were doing swallow studies to get a baseline to figure out, see if we could use it to figure out like prognosis and a lot of other important variables. And what I was finding is like, oh, this child has a narrow tongue base. Is this like an early sign of neuromuscular degradation? We have no idea because no one's ever studied this at this kind of level of granularity. But also for like, big ones, penetration and aspiration. I think we have such a referral bias in swallow studies where, you get a referral from pulmonology and they're like, oh, this kid has recurrent respiratory infections. You see repeated penetration based on the literature. You're like, okay, let's thicken it. There we go, right? But I think we don't have clear knowledge of what is normal. And in infants, especially where they have immature neuromotor pathways, like you don't expect a baby to get up and walk without falling down. Feeding is like the one skill that they need to be able to do to achieve function at birth, but that doesn't mean it has to be perfect, right? And I think the data that we've published to date shows that it's not perfect. Like kids show signs of aspiration during bottle feeding when they're young. So this is really my question of like, what is normal? How can we make all these recommendations? These are big recommendations we're making when we don't even know what normal is. So what I started out doing was trying to tackle this in a subset of patients, and that was specifically preterm infants. So many of know, the vast majority of preemies are going to have some type of feeding, swallowing problem at their hospital stay. But for the majority of these, as they approach term, then these are going to resolve, right? And so this is what we would consider are like typical preterm feeders where they have general functional problems, but they will resolve. Then we have this other set of preemies that they don't follow this normal trajectory. They're having trouble feeding, generally speaking, throughout, right? They don't get the full oral feeds at the time that they're term. And oftentimes they end up getting an instrumental assessment around that time because people are tired of saying like, why have they not been progressing? Maybe aspiration is a reason. And when I would have that happen clinically in like referrals for swallow studies for patients like this, if I saw aspiration, I would always wonder, well, like, are we just seeing aspiration in this kid because we are taking like the swallow study and we're going to blame their other symptoms on that? Or maybe if we did swallow studies on all preemies, like the healthy feeders and growers, maybe they would aspirate too. And we're actually like not even like, we know swallowing problems and the aerodigestive tract is so complex, right? And we could do a swallow study, everything looks perfectly fine, and the baby still has functional feeding impairments, probably from something lower in the GI system. So I often wondered if they were using like aspiration as like the oh yeah, this is the problem, we're going to focus in on this. And so yeah, that's kind of what originated this study. So what we did is we did swallow studies on preemies that wouldn't clinically get swallow studies typically. So yeah, what did this include? Well, they had to be less than 37 weeks gestation. They had to be inpatient at the time. And at our hospital, feeding therapists see the NICU babies for every day. They see them for feeds. And so I would say they're very well calibrated to infants that are following like a traditional, typical feeding trajectory versus those that are having bigger issues. Infants were excluded if they had prenatal drug exposure, syndromes, genetic anomalies, comorbidities. And then we did a swallow study, and then we followed them for 2 years. And we looked to see any of the kids that were eventually referred for feeding therapist, any of the kids that had poor weight gain, if they had any type of respiratory morbidities like pneumonia or just recurrent respiratory infections that would be potentially associated with dysphagia, or if they needed alternative nutrition, we excluded them. And some of this was probably more conservative than we needed to be. As you can tell, like poor weight gain can be more than just like a feeding biomechanics issue, right? It can be other things as well. Or sometimes like NICU babies are referred for feeding therapy just because like, you know, mom might say one like keyword, and then because they have that history, they're kind of referred. But we wanted to make sure that what we were characterizing as like typical, there was no chance that these children ended up having like these functional impairments in the end. So here you can see our sample. We had the average age at swallow study was 36 weeks, but as you can see, it's plus or minus 1.3 weeks. So I can't see my comments here. I'm trying to recall, I think the youngest that we did a swallow study on was 34 weeks postmenstrual age, and the oldest, you know, being 36 weeks and change. So we had some very young infants that did remarkably well. I was quite surprised. So we then scored those swallow studies with the baby VFSS IMP. And if you're not familiar with this tool or the adult tool, generally speaking, you have the different physiologic processes that are collapsed down into domain scores. So here you can see the different domain scores for pharyngeal swallow initiation, palatal pharyngeal approximation, airway invasion, laryngeal closure, aspiration, and pharyngeal transport. So red over on the right is like the worst score you could generally get, and blue is the best. And so I think like this in itself is something that requires a lot of study in healthy normal infants, because we're saying that this is the worst score you could potentially get, and that these scores are like ranked, right, where like a score of 1 is better than a score of 3, but we've actually never studied that. Maybe it's normal for babies to initiate in the piriform sinuses, and so adding like a score of 3 for that is actually inappropriately making them have a high score that shouldn't be marked as impairment. We don't know. That's kind of the first step in what we're doing here. So you can see here the different domain scores. And I think this is a key point, right? Like you can see where these kind of fall on the spectrum of like the worst possible score. And so like aspiration, we'll dive into it more, was very uncommon and is really scored where you would expect. But otherwise, like these are pretty middle of the road as far as like where they are in the spectrum of how well you could perform. So just looking at some of the different components to break them down, we found that generally speaking, when we looked at the worst score that infants got across all swallows. Now, for the paper, we just finished the final analysis of this and we'll be writing it up over the next couple months. We will be reporting on more than just the worst, because I think that's important to report on, but also like what is their average? What is, you know, other things probably help quantify this picture a bit more. But you can see if you report on the worst, generally speaking, at some point in the feed, infants oftentimes had 3 sucks per swallow or 2. Generally, they didn't keep to 1 suck per swallow the entire feed. And this is well within like published research of like what typical like suck to swallow ratio is. I should report all of these babies were evaluated with a Dr. Brown's preemie nipple with thin liquids. Oopsies, I'm sorry. Some other ones that you'd probably find interesting to your kind of clinical care. Generally speaking, pretty much every baby at some point in their swallow study would let the bolus escape to the pharynx prior to initiating the swallow. And this typically goes hand in hand, at least the literature supports that if you suck more than 1 time per swallow, a lot of times babies don't contain the bolus in their oral cavity for all of those sucks. They often let it spill into the pharynx. Going back to swallow initiation, almost every baby in this study initiated the piriforms at some point in their study, which again just further speaks to like, we need to know what healthy babies are. These are preemies, so we would expect these guys to perform a little bit worse than healthy peers. But still, generally speaking, if every preterm that doesn't end up going on to have functional feeding problems initiates in the piriforms, I think that's pretty notable. And then generally at some point in their feed, they would let it sit in the location where initiated for 2 seconds or greater than 2 seconds, I should say. Nasal regurgitation was notable in this group, and I would say more so, this is anecdotal, more so than I see in like healthy term babies otherwise that are coming in with like respiratory infections and things. So you can see that it was very common to have trace or narrow contrast entering up into the nasal pharynx or the nasal cavity based on this. Now looking on to airway invasion and laryngeal closure. So generally speaking, penetration was extremely common. You can see that here. Very few kids, I would say over about almost 75% had some intermittent penetration. And you can see that in the early laryngeal closure. They had trace or narrow incomplete laryngeal closure. Interesting, for late laryngeal closure, a fair amount of them had trace still left there at maximal laryngeal elevation, which I think is quite notable. But generally speaking, if it was going to happen, it was going to be during the swallow. It was very, like, it wasn't like before or after, like we often see in our neuromuscular patients. Penetration was often intermittent. We actually quantified like the percentage of swallows that this happened on for future. It wasn't typically repeated, which I know like Claire Miller's work has done research looking at repeated penetration and the association with aspiration. So that's notable as well. And then on to aspiration. So aspiration was really, really rare in our sample. We only saw it in 3 infants, which I think this is actually a typo. It was 11% of the sample. So, that shocked me. I was really expecting that if we were doing swallow studies on a 34-weeker, I was totally prepared that they were going to aspirate, just expecting that they're not even supposed to be eating now. But that was really not the case overwhelmingly. And if it occurred very frequently, it was like so small. Like we're talking about such trace aspiration that it could easily be missed if you weren't reviewing it closely. So there wasn't any like really gross aspiration event. It was trace, sometimes more than trace, but even on the one more than trace case, it was very debatable on if it was trace or more than trace. I'll put it that way. Going back to kind of limitations of a categorical score, which is inherent to any categorical score. And then on to bolus clearance. So turns out narrow for tongue-based retraction is extremely common in preemies. And in talking to Heather McGee, who's really involved in this now, she's at MedU of South Carolina. A lot of this is because this outcome is so dependent on head position. So if their head is even turned just a little bit, then you're getting the other side of the vallecula. And so then it's looking wider than it actually may actually be. So narrow was the dominant worst case score for tongue-based retraction. And interestingly, PES opening pretty frequently was partial. I think it was in 3 infants, just off the top of my head, they actually had complete PS opening and then followed by it was what you would have to describe as regurgitation of the bolus. Like it was retrograde flow through the bolus up into the piriforms. But it was interesting because it wasn't like this massive column of barium coming up from below. It was like it had just gotten through the PS and then it kind of popped right back out, which was a really interesting pattern I've not seen otherwise. So I think that's an interesting phenomenon that we'll be putting in that manuscript as well. And then residue. So, trace was generally the dominant amount of residue, which I think in adults has been normal, is a report of normal variation. A collection was also reported, but I would say this would be on the small collection of residue after the swallow. So again, the times it was collection, it was very much borderline between trace and collection, not like a huge amount. So that's where we are at now from the preemies perspective. When we're reporting on this in the paper, we have it categorized based on differences in function. So some of the kids were pretty much at full oral feeds. They're taking 75% or more of their prescribed intake. And we are comparing these, the integrity of swallowing between those groups of function versus dysfunction to see which of these outcomes actually is the most clinically relevant, which I think is going to be helpful in us in looking beyond penetration and aspiration. Okay, before I move on from here, are there any questions pertaining to this study or what we found in it?
Looks like there are a couple. So one question is, does the data that was gathered differentiate skill level between the gestations, such as a 34-week baby versus 35 versus 36?
Yes. So we have all that data. And I will say, like, just like at a high level, there wasn't a profound difference that I could see, like anecdotally. I'll have to look at the data. You'll have to stay tuned for the manuscript. I can't recall the exact analysis, but I would say what blew my mind was that like gestational age and postmenstrual age wasn't as profound of an outcome, like as of an influencing variable as I would have anticipated. Now, this is a small data set. So if we had more, you know, maybe it would have been found to be more significant. I think this was an N of 19, but still like pretty substantial relative to like typical feeders. So I think it comes down to like the fact that we are only taking kids that were functional, which is probably why we don't see a huge difference there, is that it's a sampling bias. If we took all comers, I'm sure we would probably see that those that had a younger gestational age and that were a younger PMA had reduced integrity probably.
And I guess that's really hard because if they're not functional feeders, are they going to be able to perform the way you need them to in video fluoroscopy anyway?
Exactly. Yeah.
And then what position were babies fed in, a cradle hold, on face or sideline?
These were all sideline. And interestingly, I asked the feeding therapist during the exam. So the feeding therapist that was their primary clinician came down and I said, you know, if you feel like the baby needs to be paced because they are like during this exam, they're not going to maintain cardiopulmonary stability. Like you can see they're not breathing, certainly pace them. Like we are not going to like cause detriment to the infants. But what I don't want you to do is just like pace generally. Like I don't want you to pace like every 4 sucks, like sometimes happens clinically across the board, because we want to see what they can do on their own, you know, without you assuming that they're going to need these supports. This is like the purpose of this exam. So, you know, I off the top of my head, I can't remember what percentage, but there's only a handful that were actually paced during the exam. Now, again, this is 2 minutes and 30 seconds. So if these babies didn't get paced for the entire feed, do we think that it could have resulted in different outcomes? Certainly, maybe that's the case. But we really tried, we fed them in sideline, but we really tried to take away other compensatory interventions unless it was like absolutely necessary.
Right. No other questions there at the moment?
Great. Okay. All right. Well, I think we have a little bit longer. So let me just see the options here really quick, and then I'll figure out which is most exciting based on where we're at. Okay. So would you rather hear about, well, I'm just going to make an executive decision. This will be easier. Okay. So this next one is a little bit more controversial. So, you know, this kind of arose at the time I was doing this preemie study I just presented. Like I said, when I'm doing research, it's a kind of a fun position to be in because you can watch clinical care when it's not your patient. You view things in a very different lens. And I think it affords you the ability to be more critical, but I think also in being critical, it's important to realize you're having the opportunity to be critical because you're not having to you're not in the trenches right now, which is always something that I'm curious about. So when we were doing this study, this was sort of like a much bigger project. We're trying to, I think many of you heard me talk about it, develop a smart bottle to diagnose swallowing problems without fluoroscopy, which is well on its way to becoming available. Well, in terms of FDA processes, so it's all relative. But But in doing this study, I would watch the feeding therapists, and some of the babies we included in the study were babies where it was clinically indicated to get a swallow study, not like the ones that I was just talking about. And so I would watch them do the swallow study. And then part of that study was to look at their charts after and follow up on like outcomes. And what was mind blowing to me was the number of babies. Now we're like at a big medical center where we have, at our hospital, we're going to get the sickest of the sick babies relative to our hospital network is quite large. And I think this might be unique to the States, but you'll have like the primary big children's hospital downtown, and then you'll have like, 10 minutes away, you'll have another children's hospital. 10 minutes from that, you'll have another, and they're all affiliated. But usually the acuity of care you get at those ones is less severe. And so ours usually gets the really, really sick kids that have a lot of problems. And so I would watch these clinicians do swallow studies. They would be doing them because they're clinically indicated. The swallow study wouldn't show any aspiration occurred. Like these would be generally babies that were like term, they weren't taking full PO, people were getting ready to like, get them out the door. So we did a swallow study. So no aspiration was observed. And the clinicians noted that in the reports, no aspiration. Sometimes they would say penetration, but not even that all the time. But then when I followed them the next week, I would see that the baby was on thickened liquids. And this didn't happen all the time by any means, but like it happened enough where I was like, what is happening here? Like, what is going on? Why? I mean, that was like my question, right? Why are we doing this? And so at first, I'm first to admit when I'm not making good decisions. And at first I was very judgmental about it, right? And I was like, this is bananas. Why are we doing this? This is crazy. Why even do the swallow study if you're going to be thickening them anyway? Like, that's my question. So after seeing this a number of times and kind of getting off my pedestal, I was like, continued to follow the charts. And a lot of the times the babies like, did better. These would be babies that like were not taking feeds forever. Like their trajectory was really slow. And as soon as they introduced thickened liquids, like the babies did a lot better. And so then I was like, well, I think this is, not an ideal practice unless we actually understand what's going on and if it's helpful. So let's take a look at it. And so that's what we did. We did this study really looking at, what if we're missing aspiration on a swallow study was like the general concept. So like my thought is these clinicians are thickening these babies' liquids because they're having clinical functional feeding problems at term. And we know that swallow studies are a moment in time. Like we just talked about that, right? And we don't really know how to translate that information very well. Like if you don't see aspiration, but a child is having functional problems, what is the outcome that you use to say, oh, they probably are aspirating, but you just didn't capture it, aside from repeated penetration, right? So if you look at the research, it supports this kind of concept that aspiration can be missed. So Duncan et al. In a heterogeneous sample found that for infants who had penetration on their initial swallow study, that 26% that went on to have a follow-up exam then had aspiration on that follow-up exam. So again, do we think that they got worse over time? Maybe some. Maybe they had like heart surgery or, they had a procedure or something like that. But generally speaking, probably not. It's probably sampling bias, right? We have, more data kind of supporting this concept as well. So showing that 33% had aspiration on follow-up. So big picture, like over a quarter of infants who do not exhibit aspiration on their initial swallow study will aspirate on a follow-up exam, okay, based on the data that we have right now. When we're specifically looking at preemies, and I think all infants in general, but preemies, the younger the infant, it just seems like we have a lot more variability in integrity of things and performance. And so in this study, what we did is we tracked the preemies from this study that I was just looking at, and we looked at what are their clinical symptoms of impairment at bedside for 48 hours prior to their swallow study. And here you can see them kind of reported here. Most of it was like fatigue, not finishing feeds, but we certainly had apnea, tachypnea, cough, things like that. And then we video recorded their feed during their swallow study. And we found that they virtually never showed the same symptoms that they were being reported on clinically, aside from pulling away, which happened half the time. So it was like a 10% concordance in symptoms. So this, again, just further stresses, like, clearly I've done a lot of research with swallow studies. I believe in this tool. I think it's a good tool. But I think it's always important for us to question what we hold like dear to our heart in terms of like, we need to advance the field. And even if it makes us uncomfortable to think about like looking at the data for what it is and trying to interpret that. And so I think the data, at least for preemies, does suggest that whether it's their variability or not, is that we're often not capturing the types of problems that people are concerned about in those few minutes that we're in fluoroscopy suite. There's been studies to show that thickened liquids can be effective even if aspiration isn't seen. Okay, so like the study is found that thickened liquids reduce vomiting and respiratory illness and resistance to feeding, cough, congestion in a heterogeneous population. And Duncan's study did this as well. And so what we did is we polled infants who were characterized as like these troublesome feeders. Their term, they weren't achieving full feeds. They had a swallow study done, but there was no aspiration observed. Okay? And they received thickened liquids. Now, I will say, like as part of the sample, this went quite a ways back. And so some of the infants in our sample, which I think is important given what we talked about earlier, had their swallow studies done at 15 pulses per second. They were not all, it was about half were 15 pulses per second, with the others at 30 pulses per second. So I think that's important to kind of keep in mind in the context of like, the swallow study didn't pick up aspiration. Would more have picked up aspiration if it was 30? I don't know. It's a great question, right? But these are infants that ended up getting thickened liquids. And then we had a control group that we used as a comparison. And these were age and morbidity matched to the troublesome feeders. They didn't receive a swallow study because it wasn't clinically indicated. They got to full feeds and they never received thickened liquids. And we looked at a bunch of different outcomes. So for the sake of time, I'm going to kind of jump to like the main points. But overall, what this is showing, we had 19 infants in the treatment group that were thickened and 19 in the control group. And there were no significant differences in gestational age, comorbidities, and things like that between the groups. So here you can see these were the infants that ended up receiving thickened liquids. So at the time that they received their thickened liquids, they had been trying to feed for, over a month from the start of that time, and they were still only taking about 40% of their prescribed volume. So these are kids that just were plateauing on the progression. Thickness levels were not controlled. This was a retrospective study. So the majority were mildly thick, but some of them were slightly thick, and the majority were provided thickening with an oatmeal cereal. And the big finding we found is that we monitored how much intake they had 48 hours prior to thickening and 48 hours after. And we found there's a significant increase in overall transfer the 48 hours after thickening, which was a significant difference. And that actually 70% of these kids ended up getting full oral feeds, which happened on average 8 days after thickening. And this was striking to me, because if you go back to this slide over here, like these were kids that had been working on feeds for 38 days and they were still only taking 40% of their nutrition by mouth. And so within 8 days, we had this pretty drastic turnaround. Now it didn't work for all. So 30% were still discharged on a 2 feed. They did not achieve full oral feeds at the time of discharge. So I think that's important to keep in mind. This is not like a beautiful magic resolution, even by this is a small retrospective study. So then my question here was well, maybe these kids were just on the cusp of getting to full feeds. And if we were just patient, because we're known for not being patient in the States, that they would have achieved it, right? Maybe that's the case. Because I kind of, to be honest, I didn't really want this to be true, because I was this goes against everything I've ever talked about in every talk I've ever given. So this isn't really fun from a pride perspective, right? So that's where the control group came in. So what we did is we tracked the control group for the overall transfer, the prescribed intake, from the start of oral intake to when they achieve full PO. So you can kind of see that on average, that generally speaking, typically developing in preemies increase 4% prescribed volume per day. They get to full oral feeds within a few weeks on average. And they kind of have these like different periods. So we like have this like slow start. Then we have a pretty steep improvement, right? Like you can see it, like they're increasing feeds, like a volume of feeds a lot for a while. And then more of like a steady kind of incline to the finish. And so what we did is we compared this control, this blue line that we just looked at, to those who end up getting thickened feeds. So this was, I mean, like this graph is beautiful. I think it's really showing that these kids that end up being like the troublesome feeders that aren't getting to full feeds at term, they really have a slower trajectory right from the beginning. So like if you track these, you could probably predict to some degree like those that are going to end up having longer issues than others, with an increase overall in only 1% prescribed volume per day. And this was a significant change. And here you can see when thickened liquids were applied. And so you can see that this like had this tremendous jump in trajectory to this, actually it changed to the 4% that this other group was on. So in contrast, you know, to what we were having, this doesn't really seem to, these slopes don't suggest that this is just like a developmental change, that kids are steady and then they shoot up right before they get to full feeds, which is what we don't see clinically, right? It's like kind of more of a steady progression. That something, we do have something that's going on here. Okay. So I know we're at time. I'll stop here, but what is this? I think the first thing is this was just accepted for publication. This should be out. You might be able to find it now, but if not, in the next month or so. Do I think you should start thickening kids without swallow studies across the board? Certainly not. That's not what I'm saying. This was a small retrospective study. We really need like a prospective trial to understand this. But I think it's important to not take anything as like the one and only. So, you know, swallow study is a great tool. But if a child is still having symptoms and it's not resolving, then I think it's worth a discussion with the care team of like, okay, what's the risk to benefit ratio here if we try an intervention? Certainly thickened liquids are not good for a lot of reasons. I'm not saying that they are, but at some point, is that risk of just saying like, should we try it for 48 hours and see what happens worth it? I think if it was my child personally and I was stuck in the NICU and nothing was working, I would say, go for it. Let me try it, you know? So I think that's the kind of stuff that we need to think through is like, what are the limitations we have? How can we systematically look at things, but knowing that we do have limitations where we're at. And I'll end there. If there's any questions, I'm happy to stay on for a bit longer to answer them. And I hope you all have a great afternoon. And it's always a pleasure chatting with you. I hope to see you in person soon.
Thank you so much. It's so interesting to end on sort of clinical management still is key. Like you can't rely entirely on an instrumental. You still have to look at the child. It looks like there's one additional question there at the moment. Someone said, I'm interested in the average gestational age at the start of oral feeds for the babies in the last study and the average gestational age at full oral feeds when full oral feeds are achieved.
Yes. So at this, okay, I'm looking right now. PO at initiation, the average age for thickened group was 35.74 weeks. And for control is 35.51. So in our NICU, we do infant-driven feeding program. So I would say generally speaking, the time that we initiate PO is pretty or typically around like that 35 mark, just because they're not showing consistent cues until then.
And Marina's asked, what thickener were you able to use?
This was infant cereal oatmeal. That's I think 2 kids used rice because it was before we transitioned over to that, but no commercial thickener.
Because I guess that's one of the big questions for our neonates, isn't it? Is actually what is appropriate to use with them.
And I think that's like we need consensus, guys. Like that's the big thing is so much of the debate around thickened liquids and all of this is that there's really no good consensus guidelines on like what is the optimal thickener, what is and that's because we don't have research behind them. So I think that's a huge thing is like, what is the balance of risk to benefit ratio that is okay? And I think we need an interdisciplinary panel to really come to that, because until then it's going to be hospital dependent on each provider, which is really what's happening.
Yep, very much so. Same, I'd say probably the same over here.
Yeah.
Are there any other questions? No, seems like that's
great.
might be everything. Thank you so much, Caitlin.
My pleasure.
Really
I hope you all have
appreciate
a
it.
good one. Yes, anytime. I hope to see you soon.
I think we could probably keep you all day at some point. It's just
Well,
it's
I
great to
teach
hear.
undergrad, so I might be inclined to stay all day. That sounds great.
Look at that. I think it's so great to hear about some of that new unpublished research as well, and things for us to look out for and look forward to reading. Our journal club can certainly be full up for the next little while with what you do.
Sounds great. Great. Well, you have a great afternoon. Thanks for the invite to be here, and I will chat with you soon, I'm sure.
Lovely. And for all of our attendees that are still here, we have recorded this. It will go onto our YouTube page. If you haven't joined the professional network yet, please go and do that, and we'll make the link for the YouTube page. It might even already be up there, and you can search for us as well. Thank you.
Thank you. Bye.